I can hear you as well as see the screen. It's perfectly working right now.
Okay. Tell me, when do you want to start?
I'll just wait because the entire session would be recorded. I'm just waiting for Jay, who is a part of our agency, who can give us a go ahead.
Yeah, sir, just wait for 1 minute.
Sure.
Okay. After 1 minute, we will be live.
Just give me a countdown and I can start. So,
okay, sure, sir, sure.
Yeah. Dr. Shah, sir, I just wanted to give you a flow of the event. So, I will start with my introduction, followed by I'll introducing you, and then I'll give you the session, and then we again meet up for the question and answer session, and we close the event. Right, sir?
Sure.
Okay, great.
And so one more thing, the session will also will be live on the YouTube.
Oh, lovely.
Yeah. So, sir, are you ready?
Yes.
Yes.
So, sir, we will be live in 5, 4, 3, 2, 1. Sir, you are live now. You can start the session, sir. Over to you.
Thank you. So good evening, everyone. I'm Dr. Sanket Nivale, representing McLeod's Medical Affairs, and I welcome each and every one of you to this scientific feast today. And today, again, we would be having an eminent speaker who would give you all the possible experience sharing as well as knowledge sharing through this platform, which is currently live also on YouTube. I would like to introduce our speaker for the evening, who is the one and only Dr. Chetan Shah, sir, who is an interventional cardiologist, an eminent speaker by himself. A brief about his profile, which I would like to share with you today. He is a consultant interventional cardiologist and rhythm specialist at Leelavati Hospital, also practices at Fortis Hospital, Kikabai Premchand Cardiac Institute at King Circle. He's a director cath lab at Surana Sethia Hospital. He's also a director Heart Rhythm Clinic at Ghatkopar, Mumbai, India. He has done his MBBS, MD, and DM in cardiology from prestigious St. GS College and KEM Hospital of Mumbai. Then he went to the USA, where he did arrhythmia and cardiac EP fellowship from Michigan State University and University of Ottawa Heart Institute for 3 years in 1996 to 1999. Then went to the Royal Perth Hospital, Australia, and Sir Charles Gairdner Hospital, Perth, Australia, where he worked as a junior consultant in the field of interventional cardiology and arrhythmias for 2 years in 1999 to 2000. Has experience of doing more than 5,000 angioplasties, including complex coronary interventions. Currently, he is the vice president of Indian College of Cardiology. Has more than 25 publications as first author in international journals and more than 50 abstract presentation in international meetings like AHA, ACC, SAEM, NASPE. He has given more than 200 guest lectures at national and international meetings, including NIC at 2012. With this short introduction, I would like to hand over the session to Dr. Chetan Shah, who's going to enlighten us today on the topic resistant hypertension. Sir, over to you.
Thank you. Thank you very much, Dr. Sanket, for those kind words. Good evening, everybody. So what we'll be doing today is we'll be talking about resistant hypertension today, which is more common than what we think. And then we'll look at the role of the centrally acting agents, and the drug in focus will be moxonidine. So hypertension is easy to diagnose but often remains undetected, though can be controlled, often remains untreated, and despite availability of potent drugs, the treatment is often ineffective. HOT and UKPDS trials have shown that aggressive pharmacological treatment of moderate and even mild hypertension leads to better survival and less cardiovascular morbidity. So effective and long-term control of blood pressure less than 140 systolic and 90 diastolic can reduce stroke by about 40%, myocardial infarction by about 25%, and heart failure by about 50%. So what are these ESC, ESH guideline recommendations? Now, if you look at the guideline recommendations, then they have recommended a dual combination, one pill, single pill combination therapy. So, as an initial therapy, they have recommended a dual combination of a ACE inhibitor or ARB plus a calcium channel blocker or a diuretic. That is step 1. Step 2 will be 3 drugs in a pill, that is ACE inhibitor or ARB plus calcium channel blocker plus diuretic. Then step 3 will be resistant hypertension here. So triple combination plus you can add spironolactone or other diuretic. We can add alpha blockers or we can add beta blockers. Now here beta blockers can be added at any time. You know, if the patient has a specific indication for the use like heart failure, angina, post-myocardial infarction, atrial fibrillation, or younger women with or planning pregnancy. Now here we do not find anywhere moxonidine or centrally acting agents anywhere. But let's discuss about it. What are the limitations of this present therapy? In spite of using drugs from all the above classes, either as a monotherapy or in combination, hypertension still remains uncontrolled in a substantial number of patients due to poor adherence or an inadequate treatment regimen. In addition, all the classes of antihypertensive agents have adverse effects of their own, which increases in combination therapy. So, what is resistant hypertension? Resistant hypertension is hypertension resistant to conventional medical therapy despite taking 3 or more antihypertensive agents. BP more than 140 by 19 age less than 60 years, and BP more than 160 by 19 age more than 60 years. What are the epidemiology and clinical relevance of this resistant hypertension? The prevalence is not known, but observational and clinical trials suggest that it's a very common problem. In a study by National Health and Nutrition Examination Survey, participants being treated for hypertension, only 53% were controlled to a blood pressure less than 140 by 90. Now, of this participants with CKD, only 37% were controlled to less than 130/80, and only 25% of the diabetic participants were controlled to less than 130/85. In a Holland trial, 27% of the participants were on 3 or more medications. This was at a 5 years follow-up. Now, what is the etiology of resistant hypertension? It can be suboptimal therapy. The most common and mostly correctable cause of resistant hypertension, adequate trial of maximally tolerated doses of at least 3 drugs. Sequential monotherapy with the 3 drugs of different classes is not adequate. So, you have to give them together. Failure to prevent volume expansion with adequate diuretic therapy. One of the drugs should be diuretic. Once the creatinine clearance falls to below 30 ml per minute, or serum creatinine more than 2.5, loop diuretics should be substituted for a thiazide diuretic. Extracellular cellular volume expansion. Most patients have relative or absolute extracellular volume expansion. What are these underlying conditions of this extracellular volume expansion? It can be renal insufficiency. It can be sodium retention due to vasodilators. It can be ingestion of high salt diet. It can be presence of clinically occult expansion. It can be use of once daily short-acting loop diuretics. Gradual removal of fluid for BP control. So now poor compliance is also one of the causes of this resistant hypertension. Up to 80% are at least partially non-compliant. That is because of lack of knowledge about the disease and relative absence of symptoms. Hypertension does not have significant symptoms in most patients. cost or side effects of the medications, and complex dosing schedules. So, you have to make this dosing schedule very simple, morning, evening, or OD doses that will make better compliance. What are the checkpoints of this poor compliance? So, we need to educate the patient, rescheduling the missed appointments, monitoring of the drug-induced side effects, simplifying the drug regime, monitoring the drug intake by doing pill counts, physiologic changes after medication. So what are these physiologic changes? So if you look at the pulse rate, if you look at the pulse rate, if the patient's heart rate or pulse rate is very much controlled, then patient is taking beta blockers properly. If they are still high, then you suspect that patient may not be taking beta blockers. Then secondary hypertension. This is also one of the causes of refractory or resistant hypertension. Up to 11% of the patients with refractory hypertension have identifiable secondary cause. Most common are renal artery stenosis or chronic renal parenchymal disease. So let's talk about renovascular hypertension. This is renal artery stenosis. When previously well-controlled hypertension has recently become resistant to therapy in patients older than 50 years of age with evidence of generalized vascular disease, they should be examined for this renal artery stenosis. Captopril-induced renograms are useful for this purpose unless the serum creatinine is higher than 2 milligram percent. The most important investigation here is renal Doppler, Doppler of the renal arteries, which will tell us about the renal artery stenosis. Then second is the primary aldosteronism. 5% of the patients with refractory hypertension have primary aldosteronism. The aldosterone-renin ratio is useful when screening for primary aldosteronism, regardless of whether the patients have an adrenal adenoma or idiopathic aldosteronism. They respond to aldosterone antagonist like spironolactone. Then pheochromocyte. Pheochromocytoma is one of the very common causes of labile and refractory and resistant hypertension. Then what do you do here? Test for urine metanephrines and or catecholamines are used to screen for pheochromocytoma, and we need to take an endocrinologic opinion before proceeding to more expensive imaging technique in this particular problem. So, what are the drug-induced hypertension? What are the physiologic mechanisms involved in genesis of drug-induced hypertension? And what are the drugs which can cause hypertension? So, they can be NSAIDs, non-steroidal anti-inflammatory drugs, glucocorticoids and mineralocorticoids, cyclosporine, erythropoiesis-stimulating agents like erythropoietin, and illicit substance abuse. So, these are the drugs which can cause drug-induced hypertension. The most important thing in hypertension and resistant hypertension, refractory hypertension, is sympathetic overactivity. Sympathetic overactivity may be a central feature linking hypertension with other components of the metabolic syndrome, like there is a link with obesity. A raised body mass index is associated with an increased rate of sympathetic nerve discharge in skeletal muscle. There is a correlation between BMI, body fat distribution, and urinary norepinephrine excretion. Then there is a link with insulin resistance and diabetes. Sympathetic activation is a major component of insulin resistance in clinical experiments and humans with type 2 diabetes. Cardiac autonomic dysfunction occurs in 30 to 50% of the patients with diabetes and 40% of the obese patients without diabetes. Linked with other risk factors, sympathetic overactivity is also implicated in renal disease, left ventricular hypertrophy, arrhythmias, and congestive heart failure. What should be the treatment strategy? Autonomic dysfunction appears to have an important role in patients with metabolic syndrome, and treatment of patients with hypertension should take account of associated metabolic conditions as well. What are the therapeutic objectives given the adverse effects of sympathetic overactivity and the development of complications? Reducing sympathetic overactivity should be primary goal of non-pharmacologic as well as pharmacologic therapy strategy in treatment of uncontrolled hypertension. So what are the non-pharmacologic therapies? Non-pharmacologic therapy is lifestyle modification. So what are these lifestyle? So what should we do? So there should be a proper diet control, exercise, and exercise. There should be a proper nutrition, and there should be a proper sleep. So with low salt diet, low intake of sodium. There should be proper physical activity, weight reduction. These are a few important factors in lifestyle modification, as well as pharmacologic treatment strategies. So what are these pharmacologic treatment strategies? So let's target the central sympathetic outflow. The hypothalamus in the brainstem control the sympathetic nervous system activity. Stressful stimuli are transmitted from the sensory cortex to the hypothalamus and finally to the rostral ventrolateral medulla, RVLM. RVLM is a final common pathway for a number of descending influences of sympathetic nervous system activity in response to stimuli like stress, hypotension, exercise, and pain. So RVLM, the target to block sympathetic outflow, selective blockade of sympathetic nervous system outflow at RVLM prevents the deleterious effects of sympathetic nervous system overactivity. Stimulation of E2 adrenergic receptors and I1 receptors in the RVLM reduce the central sympathetic outflow. Now, what are the central sympatholytics? Now, these are the drugs which reduce hypertension by blocking the central sympathetic outflow. They can be a first generation drugs like clonidine and alpha-methyl dopa, and they can be second generation drugs. So, first generation drugs are preferential A2 agonists, and the second generation drugs are preferential I1 agonists. So, they are moxonidine is one of the main drugs here. Now, A2 receptor stimulation and sedation. This A2 receptor stimulation is mainly by the clonidine group of drugs, the first generation central sympatholytics. They reduce the central sympathetic outflow by stimulating the A2 receptors in RVLM, but they also stimulate A2 receptors at the locus coeruleus and cause sedation. So, other side effects are dizziness, the lightheadedness, drowsiness, dry mouth, constipation, and rebound hypertension. What are these I1 receptor agonists or imidazoline I1 receptor agonists? Drugs which selectively stimulate I1 receptors in RVLM also reduce central sympathetic outflow without causing sedation. That is, moxonidine is one of the main drugs here. So, moxonidine is 200-fold more selective for I1 receptors than for the A2 receptors, whereas clonidine is a non-selective agonist of both A2 and I1 receptors. Moxonidine preferentially stimulates the I1 receptors present in RVLM. It decreases the central sympathetic tone, causing a decrease in the systemic vascular resistance and reduction of the blood pressure. So, what are the fact files about moxonidine? It has a role in sympathetic nerve activity in ESRD patients. It has a role in hypertension, monotherapy compared with other antihypertensives, combination therapy, role in obese, hereditary uncontrolled hypertensives, and what are the pleiotropic benefits. So, the flow of the further talks here on moxonidine will be on the basis of these facts. So moxonidine in ESRD, again, it's an excellent drug in patients with end-stage renal disease. In patients with end-stage renal disease, a low dose moxonidine produced sustained and substantial reduction in sympathetic outflow without hemodynamically compromising them. Moxonidine monotherapy. Now, this was a well-designed 8-week trial of moxonidine monotherapy, which provides a significant reduction in the sitting systolic and diastolic blood pressure. So, the decrease in systolic blood pressure by about 19.5 and diastolic blood pressure about 10.7 as compared to placebo. Now, what about moxonidine in combination therapy in hypertensions? In elderly hypertensives. Now, in this trial, moxonidine as an add-on treatment in elderly hypertensive patients who have a specific age-related problem of isolated systolic hypertension, significant daytime blood pressure reduction of 15.4 by 7.4 millimeter mercury and 24-hour BP reduction of 14.4 and 7 millimeter mercury observed, and the conclusion was that moxonidine can be given as an add-on treatment in elderly patients whose hypertension is poorly controlled despite treatment with 2 or three antihypertensive agents. Now, so again, it controls BP very effectively in these elderly individuals. The topic study to find out the efficacy of moxonidine combinations in treating essential hypertensions. 566 patients in 138 centers in UK over 12 weeks. All these patients had not earlier responded to earlier medications. 52% patients showed reduction of blood pressure of 17 systolic and 13.4 diastolic to moxonidine therapy. 48% of non-responders, combination and amlodipine offered a greater response with about 47% of patients achieving goal diastolic blood pressure. So the conclusion here in topic study was moxonidine is effective and well tolerated when used alone or in combination with amlodipine in the management of essential hypertension. This was a CAMUS study, which was a post-marketing surveillance to find out the efficacy of moxonidine patients suffering from metabolic syndrome. And 4,005 patients at 772 practices in Germany, and there was a marked reduction in blood pressure by 24 systolic and 13.2 diastolic were observed, and it increased with the severity of disease. So conclusion was moxonidine effectively reduces blood pressure in patients with metabolic syndrome while simultaneously reducing the body weight in obese individuals. So this was that CAMUS study. Now, what about efficacy of moxonidine in obese, non-controlled hypertensives? Again, this was a study in Spain, Madrid, 112 patients, and a marked reduction of blood pressure 23/13 was observed over a period of 6 months. In addition, moxonidine improved the peripheral insulin resistance, significant reduction in the creatine clearance. So the conclusion was in obese non-controlled hypertensive that moxonidine is useful and safe in controlling hypertension in these obese individuals. So what about moxonidine compared with other antihypertensive agents? Now what about the comparison with clonidine? So first generation sympathetic. To compare the antihypertensive effect of this was a comparison between second generation and the first generation sympathetics, and the results was after withdrawal of moxonidine, the blood pressure rises gradually to base level in about 3 days against a sudden spot of blood pressure as seen with clonidine withdrawal, where blood pressure shoots up to more than the base level in 24 hours. So the rebound hypertension extremely common in patients with first generation sympathetics like clonidine. So the conclusion, moxonidine is very safe with no rebound hypertension as seen with clonidine. The 7-year clinical experience with moxonidine. Moxonidine is safe and effective antihypertensive with considerably improved tolerability as compared to earlier sympathetic. It has least adverse effects, 30 trials in 15 years, superior to clonidine, and least withdrawal effects. And side effects are as low as 5 to 7% in a post-marketing surveillance done in about 19,000 patients. The effect of moxonidine in renal functions: no serious adverse effects are seen in patients with various GFR levels and no aggravation of impaired renal function. Unlike clonidine, moxonidine, when compared with enalapril, there was a significant BP reduction of 16 systolic and 9 diastolic and 16/11 mmHg as compared to enalapril. If you compare it with nifedipine, then the blood pressure reduction were comparable with nifedipine when moxonidine was compared with nifedipine. What are the pleiotropic effects of moxonidine? So this was a study done to have a look at the pleiotropic effect of moxonidine in comparison to metformin in a multi-center prospective randomized open-label study at 11 centers in Russia. Moxonidine statistically and significantly reduced the area under curve for insulin by about 12.2%, but metformin reduced the same by about 0.7%. So moxonidine was statistically superior to metformin, reducing the insulin concentrations after a glucose challenge. So these are some of the pleiotropic benefit of moxonidine. What about the Indian clinical trials? The Indian clinical trial conducted at two places in Indore and Mumbai. This was an open randomized comparative clinical trial to evaluate the efficacy and safety of moxonidine versus ramipril versus losartan in hypertensive patients with or without diabetes. There was a significant 16.57% reduction in systolic blood pressure with moxonidine group as compared to 10.5% in ramipril and 10.54% in losartan. So, conclusion was that moxonidine could be used safely and effectively in hypertensive patients as compared to ramipril and losartan. What about chronic renal failure? When GFR is less than 30, influence of a trial of 24 patients suggests that once a daily dose administration of moxonidine 0.3 milligram per day is very well tolerated in patients even with eGFR less than 30 with no deterioration of renal function as a consequence of moxonidine therapy. And the trial concludes that patients with renal failure, the dosage of moxonidine should be individually titrated for the desired clinical response. What are the precautions we should take in using moxonidine? Cessation of combination with beta blockers. Beta blockers should be stopped first, and then moxonidine should be stopped a few days later. The use with caution in patients with the history of angioneuritic edema, and a caution in patients with eGFR of less than 60, so 30 to 16 single daily dose should not exceed 0.2 milligram, and a daily dose should not exceed 0.4 milligram in this particular group of patients. What are the advantages of moxonidine? Moxonidine is an antihypertensive agent with an antihypertensive efficacy which is comparable to that of other classes of antihypertensive drugs in use. Moxonidine improves the metabolic profile in patients with hypertension and with diabetes mellitus or impaired glucose tolerance. Useful in patients with metabolic syndrome, with obesity. The antihypertensive effect lasts for at least 24 hours and therefore can be used as a once daily dose. It is safe and well tolerated and has a less potential for drug interaction. It's safe and effective in combination therapy as well. So I stop here, concluding that this is one drug which is grossly underused and which should be definitely considered in patients with resistant hypertension. So I stop here and will be extremely willing to take your questions. Thank you very much.
Thank you, sir, for the great session. I believe with your experience and the evidence that you shared, there would be a lot of people who have their doubts cleared today with the evidence that you shared and the experience that you discussed with us today. Let's wait for a few minutes for the questions to start popping in. I think that also gives you a break to sip some water.
So the question can be on any topic of hypertension and cardiology. They need not be focused on moxonidine. So everybody is welcome to ask me questions on any aspect of hypertension and cardiology to make it an interacting session.
Perfect, sir. Nicely said. And thank you for inviting more questions with regards to moxonidine as well as for hypertension, sir. Sir, until then, just to clear or fill the gap, is it okay if I ask you a few questions?
Welcome, Dr. Singh. Thank you. Yes.
Sure. Yeah. So, sir, I just want to understand with your experience, like moxonidine, if I put my focus on moxonidine, it is more of a centrally acting antihypertensive, and it says that it acts on the sympathetic system and helps the anxiety or component to reduce, and that's how the blood pressure is controlled. So is it something where anxiety is on a check when we look in for such kind of patients, sir?
No, get me again. What was the question?
Sir, I said, like, sir, my voice is clear, is it?
Sorry.
Okay, great. So, sir, I just want to understand, like, when moxonidine, it's looking into its mechanism of action, it's a centrally acting antihypertensive, and it basically acts on the sympathetic nervous system to reduce the sympathetic activity. And sympathetic activity is directly related to the anxiety component, which is, can be identified as a sign in the patient. So, is there any tool that you check for anxiety in such patients, or is there any signs that you check for anxiety in such patients, sir?
In general, in the patients, there is no specific tool or sign, but these patients will have tachycardia. These patients can have raised blood pressure for that short time when that anxiety is there. So these are few things which can identify that the patient is having anxiety. But there are no other specific tools or signs by which we can recognize anxiety. So there are two things: a history and an examination. Detailed history should be taken into an examination of pulse and blood pressure. So if the patient is having tachycardia or increase in blood pressure for a short time, then anxiety can be diagnosed in these patients.
Great, sir. Great. I think that would give a direction for patients, for doctors actually. If we see such kind of symptoms or signs in their patients, they can think of moxonidine on early stages, which can help the patient rather than taking him to multiple drugs and still then adding moxonidine as a central drug. So, in your experience, sir, have you ever tried moxonidine as a second line? I'm sure it's not in the guideline, but in your experience, or anywhere where you see that moxonidine in the second line has helped your patients earlier to control?
See, if there are a few group of patients, if the patient has severe edema with amlodipine, the patient with the end-stage kidney disease who have severe edema with amlodipine, and they are already on beta blockers, then in this particular group of patients, moxonidine can be used as a second-line agent in addition to beta blockers in order to control hypertension in these patients.
Okay, before beta instead of beta blockers, right, sir? And sir, when it comes to clonidine, as in moxonidine, whenever it's compared as when it's positioned as a third or fourth line drug, it's always has its fight with clonidine, and there had been doctors who prefer clonidine. There had been doctors who prefer moxonidine, and even some have mentioned in the past that moxonidine is somewhere which suits the pocket, and clonidine is something. Clonidine is something which suits the pocket, and moxonidine is something where if the side effects are troublesome, then moxonidine is taken over clonidine is taken over by moxonidine. So is your experience similar, sir?
So clonidine is a very cheap drug. It's an extremely cheap drug. So if the patient is unaffording, then most physicians start with clonidine in these patients. Moxonidine is a very good drug. Maybe expensive, but the side effect profile is very good. I mean, there are very minimal side effects in my personal experience. There are lots of side effects, and clonidine is not extremely well tolerated drug in most patients, whereas moxonidine is very well tolerated in most patients in my experience. So when the cost is not a problem, I think moxonidine should be having a preference over clonidine.
Perfect, sir. Perfect. Great, sir. Thank you for that direction, sir. Sir, I think my last question would something where, just want to summarize how you, what is your approach when it comes to a patient who has been tried on 2 or 3 drugs optimally and now has been, kind of borderline tagged as a resistant case of hypertension. So what is your approach to such a patient? Like, he has come newly to you. So what is your how do you go about treating these patients? What's your approach?
In my approach, I usually try to minimize the pill burden by using combination therapy. So if I individualize the treatment. So if the patient is a young hypertensive patient with relatively relative tachycardia, that heart rate consistently remaining more than 80 and 90. So in this particular group of patients, I would not be reluctant to start them on beta blockers to start with. So I would go for a combination of a calcium channel blocker and a beta blocker, or beta blocker and a diuretic. So this is my approach in these young patients. So a calcium channel blocker, a beta blocker, an ACE inhibitor or an ARB, and the fourth drug for me would be definitely Moxonidine. Diuretic has a special role in elderly individuals. So in the elderly individual, I'll definitely consider diuretic, but not in the young hypertensive patients. Young hypertensive patients many times have working most of the time. They have to go for frequent urination while at work, so they may not prefer a diuretic treatment. So in these patients, my approach will be a beta blocker, a calcium channel blocker, ACE or ARB, and moxonidine. An elderly patient would be definitely a diuretic in addition to a calcium channel blocker and ACE inhibitor and ARB. And moxonidine would be the fourth drug in elderly individuals.
Lovely, sir. Thank you, sir. I think there are a few questions, but I've already asked a few of those questions to you. So I think without wasting much of your time as well, and respecting, that you have spared your this time for out of your busy schedule on a working day like this, I thank. I mean, it's a heartfelt thank from McLeod's, from the medical team of McLeod's as well. And it was a beautiful session. The attendees also must have gained a lot of insights, and they would be reaching you individually as well. So I thank you for being present for this evening and providing such experience to us, sir. Thank you.
Thank you.
Thank you.
Okay, thank you, sir. So now I am ending the meeting. Thank you.